Please welcome AAP California Chapter 2, Co-Chair of the Immigrant Health Committee, Dr. Lisa Gans.
Good morning, everyone. My name is Lisa Gans. I'm, as Tomas said, one of the co-chairs of the Immigrant Health Committee, as well as a member at large here for the Chapter 2. On behalf of our committee, we are so honored to welcome Dr. Anisa Ibrahim as our next speaker. She is a clinical associate professor of pediatrics at the University of Washington and the medical director of the Harborview Pediatrics Clinic. Dr. Ibrahim's specific clinical interests include caring for and outreach to immigrant and refugee populations, specifically those with medical or social complexity. She is committed to caring for low-income, socially vulnerable populations with low English proficiency to connect them to the resources and services they need for their health and well-being. She is shown to be a strong advocate for community-focused work and partnerships. Please welcome Dr. Anisa Ibrahim as she brings a unique and fresh perspective on understanding migration history and the medical considerations necessary for refugee and immigrant populations. Thank you.
Hello, everyone, and good morning. Still morning. I'm so honored to be here with you guys today, specifically speaking about refugee and immigrant health. I come to this talk from a very humble place, but also a very meaningful place, as this is the topic that I'll be discussing is a topic that I find very personal. My family came here as refugees from Somalia in the early 90s. After we had to seek refuge in Kenya and then come here to be resettled in the Seattle area. I also want to acknowledge that this talk is coming at a time where we are seeing another heartbreaking situation unfolding, and we are continuing to see people being displaced. So with regards to learning objectives, today we will talk about recognizing the immigrant children in our care, because regardless how and where we are practicing, we do have immigrant children in our care. To understand the approach of conducting a migration history, which I think is critically important to providing care for immigrant children, reviewing key medical considerations for refugee and immigrant children. That will be a brief overview because I could probably give a talk on that just in and of itself. Recognizing the gaps in care for immigrant children and identifying opportunities for advocacy and change. So first and foremost, I want to talk about displacement. In the most recent numbers, as of 2020, we have a total of 36 million children who are displaced from their country and who have become migrants. So 12 million of these children are refugees. Another 20.4 million are children who are internally displaced within their own country due to violence or political unrest. 2.9 million children are living with internal displacement secondary to natural disaster, and 1.3 million children are seeking asylum. Now, this is one of the most powerful quotes I read in the UNICEF Uprooted Executive Summary. This was, I believe, in 2017. These children may be refugees, internally displaced, or migrants, but first and foremost, they are children, no matter where they are from, whoever they are, and without exception. Now, there was a national survey that looks at how prepared are pediatricians and people in healthcare who care for children in caring for immigrant children. Are United States pediatricians prepared? And these are some of my good friends in the immigrant health sector, including Dr. Andrea Green and Dr. Kate Yoon. And what this national survey showed is that 1 in 3 US pediatricians report being unprepared for children, to care for children in immigrant families. So if we are feeling unprepared, or if you are feeling unprepared, you are in good company. I think these are a specific set of skills that we all learn to provide care for. And there are some factors that actually have helped pediatricians feeling more prepared. But these are things such as having a recent international global health experience, having a dedicated curriculum in their place of study, or being an international medical graduate. Now, coming a little bit closer to home in California, more than a quarter of California residents are immigrants, while nearly 1 in 4 residents is a native-born US citizen, but have at least one immigrant child. In total, California has over 421,000 children who are either immigrants or live in immigrant families. So we are all caring for children who either are in immigrant families or immigrants themselves. Now, the first thing I do want to talk about specifically in recognizing the immigrant children in our care is the definition of immigrant children. Now, these definitions are not only important for us to know, but they are important because it helps us understand what services these children are getting, whose care they are under, and what resources are available to them. So, and sometimes we do use these words interchangeably, but I do encourage people to know the actual definitions of these terms, because although the terms people are able to use interchangeably, the resources and supports that are available to the children are not interchangeable. So refugees are individuals outside of their country who are unable or unwilling to return home because of a fear of serious harm, and they seek refuge when they are outside of the United States and seek protection. Asylees are similar, however, they seek protection at a point of entry or once they are within the United States. Unaccompanied children, there are two key definitions to know: unaccompanied children, or UAC. The actual term for that is unaccompanied alien child, but I will not say that term again because I do have a hard time speaking that term, but that is the term what UAC stands for. Are individuals under 18 who are without lawful legal status in the US and are without a legal guardian in the US. Many of these kids we are seeing coming through the southern border of the United States, and they are from a variety of places. From Latin America, yes, Central America, yes, but at least in my practice, we've seen kids from all over the world who are taking this route to gain access into the United States. Then there are unaccompanied refugee minors who are refugee children who meet the definition of refugee and are here without a parent, but live with a foster family and are under the protection of the Office of Refugee Resettlement. And then we have undocumented immigrant children, so children without lawful legal status in the US, but have a legal guardian with them here. Children who are special immigrant visa holders. So these are children who qualify for a green card under the USCIS. And there's a special immigrant visa program. Most often we encounter these children. They are from either from Afghanistan or Iraqi families who worked with the US military. I think with the most recent wave after Kabul fell, we've seen a lot of children who do have this special immigrant visa status. However, we've seen a lot of children from Afghanistan who are humanitarian parolees who were evacuated and brought here, but do not yet have the protection of SIV status. And then there are immigrant visa holders. This is kind of a catch-all term where children who have a variety of legal statuses, including green cards obtained through family-based programs or the green card lottery. So now that we've talked about these definitions, I want to move a little bit into how the children might come into our care. And there's different pathways to care, but specifically there are more streamlined pathways to care for children who have the designation refugee, asylee, or special immigrant visa holders. The reason for this is because there is more often than not, a resettlement agency or a program that is helping children come into the care, especially health care. Here in California, we have the Office of Refugee Health. And essentially, a lot of these programs were created through the Federal Act in 1980, where the Office of Refugee Resettlement was created to coordinate post-arrival health assessments, limited time medical services, cash assistance to refugees and asylees for a limited time in order to help them become financially independent. Now we can talk a lot about how long it takes people to become financially independent, but most of these programs only offer support for 6 to 8 months. The refugee in California, you have the Refugee Health Assessment Program, and then that offers these screenings, but also provide families resources for access to primary care. Then there's the Refugee Medical Assistance Program that offers about 8 months of benefits, limited medical benefits for children who are of these classification. Now, unaccompanied children, there's many families, many pediatric practices that care for unaccompanied children, specifically UAC. These children, once they are many kids who are arriving at the border unaccompanied, and they are generally processed through CBP, so Border Patrol. But due to the Flores Agreement, there's a law that says that kids can only be in CBP custody for 72 hours, and at that point, they have to move into ORR custody. Once they move into ORR custody, these children are cared for in shelters for unaccompanied minors, where they do receive health care under Point Comfort Underwriters. It is a insurance program, which is essentially reimbursed at 100% Medicaid. They are given this care, but only during the time in which they are in that shelter. After release from the shelter, many kids lose all access to all programs and care. There are a limited number of kids who do get post-release services and care, but those are mainly reserved for kids who have medical complexity or social or some kind of mental health issue. The families who sponsor these kids they have to undergo a pretty long vetting process, including a home visit, to ensure that they are qualified to care for this child so that they can get these post-release services. Otherwise, the care that kids get after they are released from these shelters is highly variable and it's really dependent on local healthcare laws. And then pathways to care for undocumented children. These pathways are highly variable, and it really, more often than not, we are really seeing kids come to us in kind of an emergency setting. They don't feel safe or comfortable or don't have the means to access healthcare otherwise. So you might be interacting with a child either inpatient or in the emergency room. California, fortunately, does have Medi-Cal coverage for undocumented children since 2016, and the income limit up to 266% of the federal poverty level. And many of these kids do rely on safety net resources, such as county hospitals and free clinics. So now that we've talked a little bit about the pathways to care, the definitions of the kids and the pathways to care, I do want to talk a little bit about the approach to clinical care. Now, this is an approach that I humbly want to present from the perspective of my colleagues and I in Seattle, but we do use a lot of the guidelines from the CDC, the International Organization for Migration, as well as the AAP Immigrant Health Toolkit, which is a wonderful resource. Our approach to clinical care for refugee and immigrant populations includes two things. The first one is migration history. And if a migration history is the only thing that you do during the first visit with a new immigrant family that you've identified, I think that is a successful visit. And I will tell you why in a little bit. Then next is preventative health services. And then preventative health services includes an introduction into preventative health services, what they are, the importance of them, and then really partnering with the families to introduce them to our healthcare system. And then both those two together is what we call migration health maintenance. Now, this is, I won't spend too much time on it, just given our limited time today, but this isn't a proposed patient care plan that we use in our clinic, and we are a teaching hospital, so we use this both as a workflow for everyone, all the providers in the clinic, but we also use it as a teaching tool for our residents about how to approach a migration health maintenance or just visits with immigrant children. Now, the provider first visit, there is, we talk about the timing, how often we should see kids from the first time that they are identified as a child or an immigrant child. Sometimes this is the first visit, sometimes this is 2 or 3 visits later, and that's completely fine. The goals of the first visit, as you see, the goals of the first visit are kind of robust for our initial visit, but many times we are seeing newly arrived refugee kids, or we are seeing children who are unaccompanied coming through the border for their initial medical exam. But I do have highlighted there the migration history because I do think that is one of the most important things that we should be doing. There are other things that we discussed during that first visit, if time permits, including presumptive treatment for endemic infections. There are connections with people such as social work, nutrition, or the medical legal partnership. And other times it's really just an introduction to here is our team in the clinic and here's who will be caring for you. There are recommended lab lists and then immunizations that we always discuss. This is a lot to do in one visit, but it is an introduction to all of these things. And then typically we like to see kids and families 4 weeks later and then 2 months after that as well. So the migration history. Migration history, I think, is one of the most important things that we are doing, not only because it helps us risk stratify, but it's also important in getting to know the family and building rapport with them. Later on, I'll talk a little bit about trauma-informed care and then approaching this topic with intentionality, but right now I'll just kind of go over what a migration history is. First and foremost, it is asking these questions because you think it's really important to paint a clear picture for the child in front of you, but also the family and what they've been through. Location of birth is important. I'll give you an example because you can always assume where they are coming from as the location of birth for all the children in the family. Recently, after Kabul fell, there was a mass evacuation of everyone. Everyone was put into a plane and evacuated to different sites. So we had families who had a lot of pregnant women, a lot of families who had kids who were born in Kabul, kids who were born in Spain, kids who were born when they came to the safe havens here in the United States in Washington, D.C. So it's very, very important to ask at what point this child was born and if it was a rural or an urban setting, and what kind of what the general health situation was when the child was born. The number of years in the United States is important if this is not a brand new immigrant who's coming to you. Many times we will have families who secondarily migrate, who come to the United States, live in one state for a little while, find out that their community lives in a different section of the United States and will migrate so they can be near people and near resources. The nationality is important. Just because a person is from a country does not mean that is the nationality that they identify with. And their preferred language is important. And it's really important to say that we want to provide care for you in the language that you prefer. I see this a lot with a lot of my unaccompanied children who come through who are from Central America, who come through the border, and they think that they need to speak Spanish in order to communicate with me. And I make a very intentional discussion with them at the beginning of that to say, I want to communicate with you in the language that is best. And many of them at that point will say, well, I actually speak Quiche, or I actually speak Mam, which are indigenous Guatemalan languages, and I speak just enough Spanish to get by. That's important because the questions that we are going to be asking, we want to make sure that we are actually having a conversation that is well informed. So I always ask preferred language regardless of where they're from. This is also a great time when you're first meeting someone to really discuss what languages are you literate in? And most of the time, this is a question for families. I have families that speak 5 languages, which is incredible. It is a gift, but they do not read or write in any language. And that's something that you should ask at the first visit. Because if you are asking at visit 4, visit 5, many families will say, what have I done to make you ask me this question, right? What have you seen? But if you ask it right off the bat in the first visit, they assume that this is just another question. So asking, what is your preferred language? What language are you most comfortable in? And do you read or write in any language? Immigration status, we just talked about, is important because it does identify which resources and the pathways to care. I do have an asterisk by that because I think prior, like 5, 6, 7 years ago, it was safe to document this in the electronic medical record, but I will leave it, what I will say is I do not feel as safe documenting this as I used to. Just because we've seen that these can have negative consequences for families, but it is important for the clinic or the community to have ways to discuss this status so that they are able to pass information forward. If the family does have a legal status, in which they are documented, it's very safe because they are known to the system. But for many families who are undocumented, if they do reveal that information to us, it's important that they know we'll keep that information safe. The migration path to the United States, again, we always ask because that is meaningful for risk stratification, but also how long a family has been in migration. Right now, again, I'll give the example of Afghanistan. When Kabul fell, it was a very, very quick trip with people getting evacuated, going to a safe haven straight to the United States or having an international safe haven such as Doha. Prior to that, the average number of years in a refugee camp was 17 years. So there are many families who have spent their many, many years of their lives in a refugee camp. There are kids who have known nothing other than a refugee camp. So that question is important. Then we always also ask about healthcare access and what kind of access they had prior to migration and during migration, if that makes sense for their timeline. I always ask about education access because globally 258 million children are out of school. And when we come here and we are emphasizing or prioritizing school, it's important to know where that child is coming from if they had access to education so that you can adequately advocate for them in their school systems. And then family. I think family is one of the most important things that we often forget to ask about. The United States, we're very used to the concept of a nuclear family. In many parts of the world, that is just not the case. So many families have had a lot of stress because their families have been ripped apart, and it's really a matter of life or death, who gets to come and who does not. Many families do have a lot of people who they've left behind. Again, recently I've had many families who are coming, especially from Afghanistan, who've had to leave children behind because they didn't make it onto the plane. I'm talking about 15-month-old children, and you can only imagine the mental health of a mom who had to leave a 15-month-old behind or risk, and who's pregnant or risk death. So migration health maintenance, these are the rest of the things that we do in that initial medical visit, and that's that introduction to preventative health that I spoke about. Screening labs, and generally prior to this, I would give many slides discussing screening labs, which screening labs are important for refugee and immigrant populations, but I have a wonderful resource that can actually help out with that. We talk about growth a lot because one of the most common things that does come up for refugee and immigrant children or migrant children in general is malnutrition. We talk about developmental screening, but again, this is developmental screening is something I generally say for the second or third visit because the family must be comfortable with you in order to discuss something as precious as their child, and specifically as precious as their child's developmental status if they are developmentally delayed. That is something that is deeply stigmatized in many parts of the world, including here in the United States. So they have to know you and trust you before they talk to you about something like that. Mental health screening is something that we do that's important, and it's actually a part of the health assessments that do happen at the refugee screening clinics, and then immunizations, of course. So screening labs, this is the number one reference that I want people to remember. It's called CareRef, and it's a tool that guides clinicians through conducting a routine post-arrival medical screening. It is for newly arrived refugees to the United States, but it also does apply to immigrants. And I would also argue to unaccompanied children who are coming. The list of ORR labs that for unaccompanied children is different than what the CDC and the AAP toolkits recommend, but that's a point of advocacy, and I do think that all kids should be getting this kind of care. So for CareRef, what you do is you input essentially the information that you do have, whether they're a refugee, which country they're coming from, and whether or not you have information on their past medical history. CareRef will then provide you CDC alerts, which screening labs to get what to look for in a physical exam, immunizations, mental health, and also health profiles of the countries that people that they are coming from. And I think this is this is through the University of Minnesota, and it's one of the most useful websites that I typically refer a lot of my colleagues who are seeing immigrant children too. There are common health concerns that that do come up time and time again, and I could, like I said, I could give a lecture just on these common health concerns. Overall, what I do want people to know is when most immigrant children are coming here, they are generally healthy. Right? They are generally healthy and many times do actually have better health than the general population that they're immigrating to. However, if they are do have some kind of medical complexity or a medical issue due to access of health, healthcare, et cetera, there is a chance that they have not received the services that they need, so are starting off at a state where their health is not optimized, and there's a lot more that we need to do to help them get there. Malnutrition is a very common thing, and it's malnutrition across the board. So we see people who, kids who are severely underweight, kids who are severely overweight, and also kids who are stunted. And this is due to a variety of reasons, including food insecurity, housing insecurity, but also endemic infections and infectious diseases and diarrheal illnesses such as Giardia. Infectious disease is another common thing, and for presumptive treatment, we talk a lot about things that we focus on, and what if people are arriving here as refugees, things that panel physicians overseas focus on. This is tuberculosis, this is hepatitis, but they're also endemic infections that we provide presumptive treatment for, including schistosomiasis, soil-based helminths, worms, and strongyloides. Developmental delay is something that we see commonly, and especially if you are an academic center or a place that gets medically complex kids, developmental delay and cerebral palsy due to many different causes is something that you will see often. Mental health concerns and then oral health concerns. And then I want to talk a little bit about trauma-informed care. And I think the approach to trauma-informed care and intentionality is something that's very, very important. And I say this not only because I'm caring for refugee and immigrant children, but I do think overall in healthcare, we should be approaching the care of children universally, as if all kids have had some kind of trauma in their past. That way, you don't have to focus so much on identifying who you need to provide trauma-informed care to, but it's something that you are doing in your practice. And there are several things that we think about critically, and I encourage a lot of other clinics to think about critically, and that is the built environment, training, and then intentionality. So the built environment is essentially strategies to manage physical space to promote comfort and safety. Walking into your physical space, do patients feel comfortable? Do they see themselves represented either in your staff or in the pictures that are there when you're walking into a room? Do you make that patient feel comfortable? Are you standing up above them or below them? Do they feel like this is a safe space for them to open up? Training is important, and this is really obtaining information and skills to promote deliberate provision of trauma-informed care. So it's not just saying we provide trauma-informed care, but it's reminding your faculty and your providers, your front desk, what trauma-informed care means, and then getting routine updates. And then intentionality with interactions with others is important, and then creating a safe, respectful, empowering visit, and then getting feedback from the communities that we serve about how important this is to them. Now, as I spoke earlier, it might be difficult walking into a room and expecting to get so many things out of that initial visit, or once you've identified that a child is from an immigrant family. But the intentionality, I think, is the most important thing. As we've said, many families have not accessed healthcare in the way that we are providing healthcare here, especially in a preventative standpoint. And the way that we approach the questions that we are asking is really, really important. So I often say something like this: I imagine you've been through a lot in your journey, and I'm going to ask you a few questions to help you take better care of you. You're welcome to share more if you like. And this is asking for permission to ask these things, but also inviting them to tell you what they feel most comfortable telling you. I also am very intentional about telling families what I will do with that information. Many families will ask, why are you asking me about X, Y, and Z that does not directly apply to this child or their cerebral palsy or their developmental delay? And I am very honest with them about what I'm doing with that information, what information I will document, and what, who else will that information be shared with. And then I do want to end a little bit with discussing advocacy for immigrant and immigrant children and families. And one of the things that I want to start off by saying is that I think just as the doctor before me said, pediatricians are powerful advocates. People look to us, our voices are powerful. I think we saw this a lot in the years when there were separation of children from families at the border, when the AAP stepped in through a lot of our courageous past presidents and the aid support of the AAP. And then when we are silent, that is also noted. So I will say that when children need your advocacy, as pediatricians, our silence is betrayal of those children and families. So advocacy has many facets and many levels. So I don't want advocacy to be this huge thing that people are afraid of. Advocacy can happen at a very personal level, local level, community engagement, really empowering communities that are from refugee and immigrant backgrounds, and making sure that we are centering the voices of those who need us to advocate for them and advocate with them. And I think one of the most powerful things I heard Congresswoman Ayanna Pressley say is, she said, those closest to the pain need to be closest to the power. So it is not our job to say what we need to advocate for. It is our job to amplify those voices and really center the voices that are of those who are closest to the pain. There's legislative and policy advocacy. There's wonderful things that go through the AAP, both at the local chapter and at the national level. Advocacy in medical education, specifically, as Dr. Sarel Shah, who is from here, does. She is working really hard to get information and teaching about refugee and immigrant health into medical education, and saying this is something that all people need to know about, and not just a select group of people. Advocacy for high quality, accessible healthcare, and then research in public health. But when we do discuss advocacy, it's really important that what we are saying and what we are doing really match, and that we are not going to do more harm than good. And I learned this through the Frameworks Institute. The Frameworks Institute is a think tank that does research on how to communicate about social issues in a way that not only is effective in the public spectrum, but also moves the needle on how people approach these things. And there are several values that they have deemed effective for immigrant and immigrant advocacy. And these include the value of shared prosperity. So children are essentially saying that children are the basis of our future civic and economic well-being. And if you're making a pitch to someone based on that value, it's very hard for them to have a comeback and say, well, no, kids are not, which we know that they are, and it's all children, not just the children who we think deserve that. But another value that's really important is the value of human potential. So essentially saying that we need children's talents and skills to be available to our communities. And this is why the welcoming and integration of immigrant children is important. And then the value of human dignity. And I think this was very skillfully used, especially by the AAP when we're advocating for children who are in cages, or children who, were being separated from their families, and saying that we have a moral obligation to respect people as people and children as children. And what we want for our children should not be different from what we want for immigrant children. Another key thing to really think about is framing, and how we frame our advocacy pitches, and essentially what we are saying, because we do not want our voices to be used against us or against the communities that we are advocating for. This is as simple as reframing things. So rephrasing relentlessly to get the attribution of responsibility. So who is responsible for a disparity or said problem? For disparities to be focused on underlying consequences, underlying causes, the shared consequences as a community, and then who has a social responsibility to fix this issue. This is, sometimes it's calling a disparity an inequity, because a disparity can be attributed to being someone's fault, right? So if we say, Black children have, and I'll give you an example, Black children have, experience X at a higher degree than white children, right? Calling that a disparity, you can blame Black children for that, or the Black community for that, but calling it an inequity that leads to a disparity puts the responsibility on what is creating that inequity, and not the people who are suffering from that inequity. And then not leaving any room for public imagination to place burden on the disparities of people in the communities experiencing adversity. So for example, this is something that we learned to do during the time of COVID. So saying something like a higher number of deaths among Black and Latino people in the COVID-19 pandemic can be explained by a higher number of underlying health conditions like obesity and diabetes. That statement does not shift that attribution of responsibility, and people can say, well, they are getting COVID-19 and suffering from COVID-19 because they have these comorbidities, and that's a personal issue, obesity and diabetes. However, if you were trying to say the same thing, rephrasing it to put the attribution of responsibilities on what is actually happening, causing the inequities, causing the increased exposure to COVID-19, saying something like, when we think about the higher number of deaths among Black and Latino people, we think about people who get sick in the first place. Who still has to leave their home to go to work? Who has to leave a crowded apartment, get on crowded transport, and go to a crowded workplace? The privilege of continuing to work from home is not available to everyone. So if you see, we are essentially saying the same thing, but putting the attribution of responsibility not on the community that is suffering. Another thing for advocacy and advocacy opportunity, and I hope to just give you a few places for improvement or a few advocacy opportunities for improvement. Number one is refugee resettlement. And I'll go through kind of what I hope for refugee groups and then unaccompanied children and just refugee populations in general. So advocacy is like refugee resettlement was not a very political or a political thing, and really had bipartisan support. When it was started in 1980, we welcomed well over 200,000 new refugees. Was our annual ceiling, and then we welcomed well over 200,000. Over the years, this had come significantly down. Since 2020, due to many issues, including using COVID-19 as a reason to not admit refugees, we have been, for the size and the wealth of our country, we've been welcoming a very, very small portion of refugees. And the advocacy for this is really to increase both that ceiling, but also increase equitable admission and ensuring that we are taking an anti-racist approach to welcoming new refugees and where we're welcoming new refugees from. Another opportunity for improvement is increasing the time for intensive case management. Right now, if you have a medically complex child and arriving to the United States as a refugee, you get 90 days of support from your resettlement agency, which is not even enough to get your bearings on how to support your child in a new country. And then support funding for community agencies to support immigrant children. For unaccompanied children in California, especially in the area of Chapter 2, last year through August 2021, the area welcomed 4,859 children who were released from ORR shelters. Specific areas for opportunity and improvement and advocacy are increasing bed capacity. Right now, since 2017, there's been an increase in 6,500. There's an increase in bed capacity from 6,500 to 11,900. And what happens is when these populations ebb and flow, when we don't have enough beds in the ORR system for children, we end up opening emergency intake sites like you guys saw in the San Diego region. And that does not provide the kind of care that children need and does not provide the kind of service that children need. So increasing bed capacity is important. Expansion of post-release services, access to and insurance and subspecialty care for children in need of care, while and after reunifying them with families so they don't lose access to that. Navigation of quality education and access to legal representation, which we know makes a difference in whether their asylum case is accepted or not. Another opportunity for improvement is access to mental health services and care. Right now, we are really looking at providing care for these children only when they come to us in an emergency setting, which we know is inadequate. We know that due to many issues during the pandemic, including isolation and just being away from families in general, that the needs for children is increasing. And then that we also need to support the development and capacity building of organizations that are already there, that have what it takes and are providing culturally congruent and language congruent services instead of assuming that we know what's best for the communities. And then this is a little bit of a different advocacy opportunity, but one of the things that we saw that was really, really important, at least in the Seattle area and through the Somali Health Board, which is a local grassroots organization that I'd been a part of, was really eliminating barriers to immigrants who are here pursuing professional careers. And one of the biggest things that I've seen is there's many immigrants who are coming here from all walks of life, who have degrees from other countries, who are doctors, who are, who are scientists who have done incredible research and then are coming here and have been forced to work low-skilled jobs because we do not accept what they their credentials or where they went to medical school. We make it incredibly hard for them to practice here. So this bill is something that we advocated significantly for, and this is our Governor of Washington, Jay Inslee, signing this bill. And this bill created a work group that will recommend strategies to reduce barriers for graduates of international medical programs to do residency in the United States and Canada, and then find places for them, because we know that there is a need. We know that there is a need for doctors, especially in rural areas, and we are preventing them from practicing, which I think is very inequitable. And then I just want to leave you guys just with this quote, and I think this quote is what really pushes me every day. I think in the care that we do, it can get hard. I think we see a lot of suffering, and especially during waves of immigration, and when we see things unfolding in the current events and things, and then when we see families in front of us telling us these horrific stories, what led to their mental health decline, what led to their PTSD, the family members they lost, it is hard. It is a little easy to get hopeless sometimes and wonder who are the good people and what change can happen. And I always remember there's always good people doing good work. And I'll leave you with this quote by Margaret Mead. So never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it is the only thing that ever has. Thank you.
Thank you so much for such an inspiring talk, and you covered so much wonderful information in such a short time. One of the questions I have is, you mentioned something that I often struggle with in my clinical practice is the extent and how to document in a way that communicates to other team members who might need to know, not necessarily the details of the immigration status, but the situation that the family might be in and how we can best support them while still respecting privacy, especially since with recent years, we've seen that medical record can be subpoenaed and things like that. So could you expand a little bit on how you guys handle that in your clinic and any advice you might offer on how to covertly communicate to those who need it without endangering families' privacy?
Right. So I think that's such a good question. I think it's something that we actually struggled with. And again, we struggled with this specifically for undocumented children because we do not want to put, or if there's a child who is a citizen that has an undocumented parent or family member. So for all other kind of immigration classifications, because those are including children who are unaccompanied, like so UAC children, because they're known to the system, we do document that their immigration status. For all others, specifically because these records can get subpoenaed. Since 2016, we have not felt comfortable actually documenting that in our electronic medical record at all, because that can cause harm. And we've also taught our residents to not do this, to do the same. We do communicate. We have the honor of having like an in-house social worker, in-house dietitian. So we do a lot of warm handoffs. And if I'm sending this child to doing a referral, et cetera, I will either make a phone call or try to do a warm handoff, social work to social worker, doc to doc, just to let them know of the situation. And then also letting them know, because that's information that I have and they might not have, that I would recommend them not documenting that information for fear of harm to a family. So it's not perfect, but I think that is what we have decided is the safest for families and really honoring the family's wishes since they've chose to share that information with us.
Hi, thank you for an excellent, comprehensive look at this issue. I have two questions, but you can pick one maybe you want to answer. The first is whether you could expand a little bit on the availability of mental health and in particular trauma-informed care mental health for so many of our refugee children who come in from places with dramatic levels of strife and violence. And the second has to do with access to education. Especially in those early months, because I feel like getting young people into educational settings is a real step toward normalization for them. Thank you.
Right. Yeah, absolutely. So I will do the one that's a little bit easier, which is access to education. I think that access to education is something that is very important for families. And we actually partner with resettlement agencies and people who are supporting them to say, like, this is one of, just as it is important for this child to come see me so I can get screening labs and treat them for medical conditions, it's just as important to get this child into a classroom. That being said, however, I think the way in which we approach these transitions is that we get the child into a classroom and we say, all right, good luck, you're in school now. And that's just not how it should work. And there should be an explanation to both parents and the school about the level of education that this child has had. I'm not sure if it's similar in California, but we have different accommodations that kids can have. And I inform families of that, saying like, you have the right to advocate for what your child needs, because many families, due to how they approach school, either back home or in a different country, will want to respect the school and just believe that the school will do what's best for the child. And although we want to get to that level, we know that we are not there. We know that kids are forgotten about if they're not advocated for. So I do have a lot of talks with the families saying, if you are not getting what you need from school, we will advocate for you. And having a every single one of our patients that's an immigrant that has a social work touch point at some point. We make sure that if it's not at the first visit, it's at the second or third visit. And then with regards to mental health, it's disparate, just like for the rest of the population. But the one thing that I will say is getting a refugee child to the door of mental health is half the fight. And that is because there are so many things that they need to do, including adjusting to here. So having that mental health discussion and framing it in a way that makes it just as important as physical health is one of the things that we can really do to change the way in which they view mental health, in a way the system views mental health as providers. And then partnering with them and saying that, that first time that you discuss mental health is probably not going to be the time when they say, sure, I'll go and address this. But just having that discussion in a respectful manner, and then continuing to open doors to have a safe space to discuss these things, I think is really important. I want to respect your guys' time. Thank you guys so much.